About one-third of patients with advanced non-small cell lung cancer have molecular drivers. And those patients should be treated with first-line oral tyrosine kinase inhibitors. On the other hand, the other two-thirds of patients who don't have drivers should receive immunotherapy. And the debate was whether immunotherapy by itself was sufficient or whether chemotherapy plus immunotherapy should be the initial treatment. So in patients that don't have a driver, a immunohistochemical analysis of PD-L1 expression should be performed. And the pathologists divide patients into three groups based on their expression of PD-L1. Those that have zero expression, no expression. Those that have 1 to 49% of the cells expressing PD-L1, and those that have more than 50% of the cells expressing PD-L1. In patients with a PD-L1 expression of over 50, there are several trials, mostly involving pembrolizumab, that compared single-agent immunotherapy, such as pembrolizumab, to chemotherapy. And the patients had a longer survival, longer progression-free survival, and higher response rate if they received pembrolizumab compared to chemotherapy. So that led the FDA to approve single-agent pembrolizumab to chemotherapy. Now, subsequent to that, there was a trial with atezolizumab in high expressors, again showing that atezolizumab was superior to chemotherapy. And then there was an IMpower study with cemiplimab that also showed in patients with a PD-L1 over 50 that immunotherapy was better than chemotherapy. So the majority of patients with a PD-L1 over 50 get immunotherapy alone. And debate isn't whether that's better than chemo as it is. There's a little bit of debate as to whether that's better than chemotherapy plus immunotherapy. Obviously, chemotherapy plus immunotherapy is more expensive and has a lot more side effects because of the side effects of chemotherapy. There's no direct comparator trial. However, the response rate with chemoimmuno seems to be a little bit better than with immuno alone, but the PFS and the overall survival seem quite similar with immunotherapy alone as compared to chemoimmuno. So since most lung cancer patients are elderly and chemotherapy is not as attractive, the majority of patients get immunotherapy alone. And then for patients who are 1 to 49, the KEYNOTE-042 trial said that immunotherapy was as good as chemotherapy, but there are many, many randomized trials showing that chemo-immuno, the combination, is better than chemo, and the difference seems to be greater there. So the majority of patients with a TPS of 1 to 49 would receive chemo and immuno. There are exceptions where immunotherapy is okay by itself in those patients, and those would be patients who are not good candidates for chemotherapy, primarily those with performance status 2 or elderly patients who are not fit for chemotherapy. And then there's actually a moderate amount of debate in TPS 0. And there are a number of trials, again, that show that chemo-immuno is better than chemo alone. The debate revolves around a trial called Checkmate 227, in which in TPS 0, there were three groups. One got Nivo-Ipi, just immunotherapy. One got chemo-Nivo, and one got chemo. And the arm that did the best was Nivo-Ipi. Now, because that was a small group and there were 3 arms, the differences were not statistically significant. And so the FDA has not approved Nivo-Ipi as an active regimen in TPS 0, even though it had the best survival. In my opinion, it's been unfortunate there's not been a follow-up trial to determine whether double immunotherapy would be better. And then finally, there are a number of combination trials with immunocombinations. So CTLA-4, like in 227, was perhaps the first, but now we have anti-TIGIT antibodies suggesting that they contribute and make improvements over PD-1 inhibitors alone in high TPS, several trials suggesting that. And now there are LAG-3 and OX40, CD137 antibodies being tested in combination with PD-1 inhibitors. So hopefully some of those will be positive, and we'll have even more patients who can forego chemotherapy in the beginning. So certainly right now, people with a driver don't get chemotherapy in the beginning, and most people with TPS over 50 don't get chemotherapy in the beginning.